I get the honor to introduce Dr. Michael Jackson again. He's been in practice for 31 years, a graduate of Baylor Dental in Dallas, my home state, Texas. He is a fellow with the Academy. He is also a doctor of integrative medicine. He got from Capital, just like Phil Mollica in the back there. He is the chairman of the Jawbone Pathology Committee, editor and contributor of the IAOMT position paper on that, the Sergeant of Arms, and the incoming Administrative Vice President. Dr. Michael Jackson.
The title of this presentation is Bisphosphonates and Dentistry, Friend or Foe, a Historical Review, Current Findings, and a Warning to the Profession. At our March meeting, we had presented the Academy position paper on jawbone osteonecrosis, and I made a mention at the board meeting that as I had continued to do research, I was finding more and more references, not of the typical jawbone osteonecrosis, but of a new type of necrosis that was being caused or precipitated by the administration of bisphosphonates. It's a class of drugs. Pharmacists call them dronates. And I advised the Academy board that I felt like we needed to alert our memberships of this, so they suggested that I put a post on our website. I hope you have seen that under the discussion section of our website. But then they also asked, when they asked me to do the other presentation, if I would go ahead and do some on this as well. So let's get started. Sorry, I keep forgetting I have to stand over here to make this thing work. That's interesting. What that says, without the committee being over it, is that it's my hope that the presentation of this information will serve as a springboard not only for the IAOMT, but for other groups to start looking at what I perceive as a looming epidemic in dentistry on the basis of what we're seeing in the last probably, from 2003 when the articles in the research started appearing until now. And I want to thank the IAOMT for allowing our committee to bring this to our members. So, what are bisphosphonates? They're a class of drugs that are used for bone-targeted diseases such as metastatic cancers, multiple myeloma, and also for Paget's disease and osteoporosis. And the main players in this group of drugs are Fosamax, Actonel, Boniva, Bonifos, those are the orals, and Zomedia and Iridia. Now, you can't watch TV at 6 o'clock in Fort Worth, Texas without being bombarded by Sally Fields and some of the others talking about these drugs to treat osteoporosis. Am I right? They are used in the oral role for treating osteoporosis, the orals primarily, although Skeletal and Didronel are used for either bone spurs in joints or for Paget's disease. Fosamax and Actonel are given primarily for osteoporosis, and the Iridia and Zomedia are IV drugs that are given for the cancers. And again, the indications are for osteoporosis, to control hypercalcemia from cancers metastatic to bone. When the bone cell breaks down, it releases calcium, and that accumulates in the bone, but it also accumulates in the blood and other parts of the body, and too much calcium can be fatal as well, as you know. Multiple myeloma is cancer of the bone marrow. Also for osteoporosis due to corticosteroids, and we'll talk a little about that in a little bit, Paget's disease and other bones with a high rate of resorption. Osteoporosis is mainly a disease in women's age 45 or greater, although men get it as well. It is believed to be due to a decline in estrogen. And when the bone starts breaking down in this manner, you get a fatty bone marrow, which weakens the bone, the trabecular formation inside, which can lead to fractures of the bone with minimal traumatic force. The bisphosphonates are given to slow down bone density, the bone mineral density reductions. We want to slow the bone resorption down, and they do so by reducing the osteoclast activity. Come on. Some cancers like breast, lung, and prostate have a high propensity for metastasis to the bone. And these cancer cells are able to turn our own body's osteoclastic activity on to break the bone down. So what is seen in these cancers is that when they're ready to start metastasizing, they will actually upregulate our own osteoclast activity. And when the bone is being broken down, that gives the cancer cells the opportunity to invade the bones. So by utilizing the bisphosphonates, which are, as I mentioned, the IV administered forms, this breakdown is slowed, and so the spread of cancer into the bone is blocked. We use DEXA testing, which is a dual energy X-ray absorptometry. It gives a value of the mineral content of the bone, and it is equated to the values that are found routinely in an average population of 22-year-olds. And then all assessments of the bone mineral densities after that are ratios of differences from the norm. So osteoporosis and osteopenia are really arbitrary values that are somewhere below the norm. My interpretation. What does this mean to you? What does the use of bisphosphonates mean to you as practicing dentists? We have to be very careful in the screening of the history of bisphosphonate use now before we start any invasive procedure. Physicians are being warned by the researchers that they need to consult with the patient and the dentist to find out if there are any upcoming invasive dentistry that needs to be completed prior to beginning the bisphosphonate therapy. Now, there are many articles out where the researchers are warning and explaining that this needs to be what is done, but I have yet to have a phone call from a physician before they started any of my patients on this class of drugs. Have any of you? One? It's being documented over and over again that the risk for the development of unhealed bone lesions that resemble osteoradionecrosis or osteomyelitis following the administration of bisphosphonates are occurring, and most of these are occurring after an invasive dental treatment. However, some are developing spontaneously without a known history of trauma. Again, these photographs come from the web. They're not mine. My photography is not very good, and I quite honestly have not seen too many of these, although I'll try to talk with you about what I have seen in my practice. This is an extraction site, and what you're seeing, this yellow material, is necrotic bone that the tissue has sloughed off of, and this is not going to get well. Not without some treatment and discontinuing of the medication, if possible at all. As a sidebar, and we were talking about this just a moment ago, this is what I was talking about. A rare transverse fracture of the femur is now being seen more often with the users of Fosamax as a result of non-traumatic injury. These types of fractures only occur, or used to occur, only 5% of the time, but are now being seen more commonly in bisphosphonate users. And this is a radiograph of that, and you can see that the bone has fractured horizontally right across the descending part of the femur down there. I got this off of the internet, and this is actually a female physician who did her own diagnosis with a reduced bone mineral density and decided to start herself on Fosamax. And as I recall, she's been on Fosamax for a couple of years. She was riding the subway home. She's practices up in the Northeast somewhere. And she was riding the subway home, and it was crowded, and she was standing holding on to the pole or a tab. And as the subway went around a corner, all she did was raise her leg up and move out to brace herself, and her bone broke. Subsequently to that, she decided to start doing some research on her own, and she's finding also an alarming number of these type of atypical fractures with Fosamax. So it's not only affecting the jawbone, it's going to be a body-wide problem, I think. The biologic action of bisphosphonates, as we said, is to inhibit bone resorption and turnover, which is caused by inhibition or actual cell death of the osteoclast. When the bone is not resorbed because of the lack of the osteoclast, then osteoblasts are also not triggered to rebuild new bone. They regulate one another. When osteoclasts are working, when they're finished, they send a chemical signal that stimulates osteoblasts. In the rare occurrences when the osteoclasts are overactive, the osteoblasts also have an inhibitory response, but they work back and forth with one another through chemical signals. So when the osteoclasts are not working, the osteoblasts are not working, so therefore the bone survives beyond its programmed lifespan and the patient is left with old bone. Old bone, of course, becomes fragile and fractures easily also. So we're treating problems, if it's mainly for osteoporosis or osteopenia, we're treating a reduced density of the mineral content of the bone to try to prevent fragility, when in actuality, because the cells are being maintained beyond their normal programmed life expectancy, that bone becomes fragile as well. I have heard at lectures somewhere that somewhere between 9 and 12 months our entire skeleton replaces itself. Don't quote me on that, I'm not sure, but I do know that every osseous cell in our body replaces itself regularly. And the action of the osteoclasts and the osteoblasts are, of course, are involved in that. The jawbone, the alveolar process of the jawbone, replaces itself 10 times more rapidly than any other bone in the body. The marrow, a little bit less fast than that, down low a little bit fast, but the jawbones, because of the stresses that are placed upon them, have a higher metabolic activity and replacement than any other bone in the body. So any procedure that involves the jawbone, you're risking a problem because of impairing the healing that can take place. So, periodontal subgingival scaling, intraosseous injections, endodontics, restorations that go down subgingivally a ways with the matrices and the wedges, traumas, either dental or masticatory, bruxing can be problematic. Blunt trauma such as accidents or assault, and especially oral surgery, extractions, and implant cases, and I was also surprised to see orthodontics come up. Bisphosphonates are chemically related to pyrophosphate, which is used as an anti-tartar component of some toothpaste, also related to the Tec-99N methylene diphosphate of the Tec-99 bone scans. Pyrophosphates are easily broken down by hydrolysis and eliminated from the urine, but the bisphosphonates substitute a carbon on for an oxygen on the backbone of the molecule, which renders them completely resistant to hydrolysis. Ergo, they stay around a while. With the addition of a nitrogen to the carbon backbone, the effectiveness but also the toxicity increases. And to date, only the nitrogen-containing bisphosphonates have caused bisphosphate-induced osteonecrosis. So here's the chemical representation of that: a POP on the backbone, easily hydrolyzed. When you substitute a carbon for that, you make it so that it's non-hydrolyzable. These chemical groups up here make it so that it attaches to the hydroxyapatite easily, and when you also substitute a nitrogen down here, you wind up with something that is much more toxic, as this shows. Research shows that the IV administration causes the most cases of the bisphosphonate osteonecrosis. The most potent, Zamedia, has produced this problem in as little as 6 months, 6 to 12 months, when administered at the recommended dose of 4 milligrams per month. Those are done IV over a 15-minute infusion. An equally potent dose of Iridia at 90 milligrams per month has produced bisphosphate osteonecrosis in as little as 10 to 16 months. And again, it talks about indications and what's causing the problems here. All right, so the history of this phenomenon. Some researchers have said that it's a new disease. And there's a quote in one of the articles that I read that says that if you think you found a new disease entity, you probably haven't done your research well enough. And sure enough, this is a revision of the fuzzy jaw that we had in the late 1880s. Fuzzy jaw was happening to phosphate miners and to people working in match factories that were making the new strikeable matches. And these people were spontaneously having lesions occur where the tissue uncovered the bone and the bone was non-vital. No treatment available for that back in those days other than palliative. They finally caught on that it was an inhalation contact, so they started using masks, and they eventually got the incidence of the problem decreased, but not before many of the workers had been permanently affected. And they actually passed laws. Congress passed some laws called the Match Workers Protection Law, paraphrased, so that certain companies could only produce so many matches, so a certain number of employees would be exposed to a limited amount to try to deal with the problem. This is a picture, a fairly famous picture of a gentleman who's lost most of his lower jaw due to phossy jaw of the 1890s. This is a diagram of components of sloughed jaw tissue that were seen to slough off spontaneously from some of these workers. Then, in the 1990s, the pharmaceutical companies decided that the best way to deal with metastatic bone cancers was to slow down the turnover of the bone, providing a less optimal environment for the spread of the disease. And in fact, and I'm not criticizing the judgment here, they were saving lives. They were extending the lives of people affected with cancer. But after a short period of time, they were starting to see cases of bisphosphonate-induced jawbone necrosis, starting in patients that had taken these drugs. The early response from the manufacturers were to say that, in fact, it was the steroids that the patients were taking, or the chemotherapy or the radiation that the physicians were providing for their care. But later studies concluded that it was the bisphosphonates that were responsible. The initial studies of this drug, or this class of drug, were done on dogs. And as it turns out, dogs are very resistant to jawbone osteonecrosis of the type that causes the tissue to recede and expose dead bone. Just recently, I found another article where and this one was in the last year or two, where they had worked on beagles. And they were giving the beagles this type of drug for a fairly long period of time and at high doses. And then they were euthanizing the animals and autopsying the jaws. And they, in fact, did find areas in the jaws that were osteonecrotic, but these animals just don't have the type of sloughing of the tissue and exposing. So the test media was probably wrong. Many articles were written by the companies and their consultants that initially denied the responsibility for this, but when they were finally pressed, they started providing warnings about possible occurrence of this when they're taking the drugs. Now, I'm seeing commercials on TV, some that are talking about the potential for oral problems and others that are not. And I think the original disclaimer was back in the back of the handouts. Novartis actually nailed the lid on the coffin when they did a study, and they showed that when chemo and radiation alone were used without the bisphosphonates, there was no jawbone osteonecrosis, but when the bisphosphonates were added, then they started seeing this. So that was the last straw as far as denying the problem. How big a problem is this for people? In 2003, now that's 5 years ago, there were 17 million prescriptions for Fosamax. And the same year, there were 6 million prescriptions for Actonel, and this does not account for the IVs that were given for cancer patients. So the potential, I feel, is huge. Let's go back and talk a little bit about the drugs themselves. The Rationale, Procter & Gamble, is used for Paget's disease. Paget's disease is when you have rapid turnover, you get bone pain, and the bone doesn't calcify exactly right, and you wind up with problems with that. They use it for Paget's disease to try to slow down the bone turnover. Skeletal is used for Paget's disease also. This one is also used for those bone spurs in the joint. Both of these are non-nitrogen containing and are the least potent of the class, and so far they've not produced any osteonecrosis problems. Fosamax from Merck is an oral nitrogen and is used for osteoporosis and osteopenia. The half-life is more than 10 years in the bone. Actonel, Procter & Gamble, is another oral nitrogen bisphosphonate for osteoporosis and penia, and its half-life is also 10 years. Boniva is a more recent one, and it can be taken daily or monthly. Again, mostly for osteoporosis problems. The IVs are the ones that slow it down the most. They're nitrogen containing, and they are very potent. They are said to be 10,000 times more potent than the original ones that were used only for Paget's disease. And their half-life, according to some in the literature, may be lifelong. Potency of drugs is measured by half-life, which means that is the expected time that the drug will remain in the tissue. So a half-life of 10 years or greater means that after a certain dosage of this, it's going to have an effect on the bone for 10 years. Some researchers, as I said, are saying a lifetime exposure or a lifetime risk. The osteonecrosis that we're seeing always begins again in the alveolar bone, and that's because of the rapid turnover rate. That is also confirmed by the fact that when we do Tech 99 scans, you always see a darkening of the diphosphate that's used in those, because it absorbs into the rapidly turning over jawbone. The osteonecrosis from bisphosphonates deprives the overlying tissue of the blood supply that goes to it from the tissue, so we see sloughing of the tissue with the bone exposure. And the diagnosis of this is in most cases dependent upon the clinical presence of the exposed non-vital bone. Any place where the trauma can occur, you're going to find these lesions forming. If you find them, they'll be in trauma areas. The definition, the official definition of this is defined as exposed non-vital, non-healing bone that is there for more than 8 weeks duration in patients who have a history of taking bisphosphonate therapy. So the diagnosis is based upon the clinical presentation rather than the radiographic or histological reports. Sometimes the jawbone radiographically can look normal, or it can also look like osteoradionecrosis or osteomyelitis. Another photograph. This one is larger, goes all the way up the ramus of this patient. Again, discolored bone. They usually smell, but the patients can maintain these. People that have Paget's disease, where there's such a high calcification of the bone that it obliterates the blood vessels, these people come into dental offices and they're wearing Band-Aids because they have draining fistulas from the same type of problem, but not caused from the bisphosphonates. These are some of the literature sources, and I wanted to put those down only because of when they started writing them. This one came from the Journal of Oral Pathology, and it was 2000. And he found that when they administrate the Fosamax, they get palatal ulcerations that they found of interest. And another one from Dr. Marks in 2003, published on the growing epidemic of Aredia and Zometa-induced avascular necrosis of the jaws. Those are for the cancer patients. One out of that's either Austrian or Australia, I don't remember. In 2003 also published again on bisphosphonates and avascular necrosis. Another one in 2004 from the Journal of Oral Maxillary Surgery. Another one in 4 where they started their study in 2001 through 2003, and they had seen 63 patients. There's another one in 2004 talking about the IVs. And this one is talking about the fuzzy jaw. Are we seeing a recurrence of in the 21st century of what we saw in the late 1800s? And Dr. Marks has written a very good textbook on the subject that was dated in 2007. My first exposure to this from one of my patients was in 1996. A patient long-standing had gone and had an implant done in an oral surgeon's office. The tooth had been restored. Tissue looked great for a long period of time. And then she came in as an emergency patient one day, and the tissue around the implant looked terrible. Swollen, bloody, sloughing. And so I don't do implants, so I sent her back to the oral surgeon for his evaluation as to what had happened. And this guy was sharp enough to take a very good dental and medical history on her and found that she had recently, and we're talking not more than 6 months, had started taking Fosamax. That's an oral one, and it's supposed to take 3 years for the orals accumulate enough to be responsible for this problem. This was less than 6 months. Because it had been less than 6 months, when he numbed her up and went in and debrided the area, he actually got it to heal. As you'll see later on, we're not that lucky in some cases. I have gone to the PubMed. This is the reason why I thought it was important to make the announcement at the board meeting at our last annual, or my annual meeting, because back then it was like 550 articles. Well, since then, the number has now been 700 articles. So I would encourage you, if you have an interest, go to PubMed or Medline and just type in the subject, osteonecrosis of the jaws, and see what pops up. Lots of research, lots of articles. Some articles, I think they're just trying to catch up because they didn't catch it soon enough. So the classification of this, they have a stage 0, which is reduced osteoclast activity and apoptosis, and reduced osteoblast activity and reduced osteoid production, but with no exposed bone. So this is a precursor to stage 1. This is one of my patients. This lady, one of my other exposures of this came in about, probably 6 months ago, and she was complaining of pain in this area down here. She had had the tooth removed many years ago and the bridge many years ago, and has been pain-free for all that time. And when I took a periapical, the bone underneath that ponic looked exactly like the jawbone osteonecrosis that we see on our other types of pathology patients that we see. But there was no tissue slough, no bone exposed, but she was describing bone pain. So we took the Panorex, and I didn't know to look at the time at this site over here, but this is a osteolytic process that is starting, but look at the sclerosis that's going around these bones over here as well. In the literature, they talk about osteolytic breakdown and also thickening of the lamina dura and sclerosis of the lamina dura, and she has the sclerotic changes. This lady has been on Fosamax for 4 months. I sent her to the local oral surgeon, and he says, yep, that's what it looks like to us, but they're not going to do anything about it, because if they go in to biopsy it, the biopsy will create more problem than she has right now. So I counseled with her, and I do this with my patients, and sometimes I'll say, not as doctor-patient, but as friend-to-friend, this is what I've learned. And I encourage you to discuss this problem with your physician and see if there's anything else that you can take for this problem. And she decided to just take herself off of it. So we'll follow her and see if something develops from that right there. Stage 1 is when you do have exposed bone that is not in excess of 1 centimeter and is not painful. That's stage 1A. If it's greater than 1 centimeter, that's stage 1B. Stage 2 is when the bone is larger and you have pain or infection. 2 centimeters or less, or 2 centimeters greater, the differentiation between stage 1 or stage 2A or B. The final stage is stage 3, where you can have multiple areas of exposed bone, but without significant clinical osteolysis or a oral cutaneous fistula or a pathological fracture. That's stage 3A. 3B is when you have all of those and the sizes are larger. So you can have significant osteolysis, the fistula, or a pathologic bone fracture. As I mentioned earlier, sometimes these exposed bone patients do not describe the lesions as painful. In other cases, they are painful. About twice as many cases that they're reporting in the literature are painful. The mandible is involved 2/3 of the time, and the molar region on both arches is affected 3/4 of the time. Now, in some of these articles, my scanner wasn't working very well at home, so the reason why I have borrowed the photos off of the internet is I could download them directly and not have to worry about the scanner. But in some of the articles, they show patients that have had complete implant full mouth restorations, and the bone is exposed all the way up as far into the frenum or the vestibule as you can see. You can see the implants going up into the bone. The bone's either yellow or black, and yet these patients are still able to maintain those using Peridex and good oral hygiene. If they get infected, they'll treat them with antibiotics. But patients that have that type of problem, if you have to do surgery on them, you may not like the result that you get. It scares me to death. So the treatment rationale is that if, after consulting with the treating physician, you can get the patient to start a drug holiday, which means discontinuation of the drug for an appropriate amount of time. In some cases, if they're small, these lesions will spontaneously sequestrate and you don't have to do anything else to them. My research shows that those are the very small lesions. In cases where no bone is exposed or only slightly exposed with no pain or infection, the treatment is palliative only. As I said, they use Peridex, good oral hygiene, and monitoring. Research is showing that debridement or surgical removal of exposed bone is not helpful and in many cases result in more bone damage with further increasing of symptoms and area of bone destruction. That's why I said that my oral surgeon friend, when he went in and debrided around that implant, was lucky. I think the fact that she had only been on the drug for a short period of time allowed him to get away with that. In cases where there's larger bone exposure with infection, pain, and/or orofacial fistula, or even fractures, surgical intervention is still the last option. They still recommend using Peridex, good oral hygiene, monitoring with the addition of antibiotic therapy as indicated. Implants, dentures, crown restorations can be worn and maintained if the infection and pain can be controlled. Surgical intervention can lead to permanent disability and disfigurement. In cases when the infection and pain cannot be managed by other means, surgery remains the last option. And there are many pictures in the literature showing total jaw resections necessary to restore, with necessary restoration attempted to restore the debilitating condition. So we're seeing titanium bars and things like that being placed. They're also in the literature showing many of those titanium bars that have been placed being removed and more jawbone being removed because the bone still failed to heal. That's what that just says there. In cases where you have hopeless teeth with decay or fracture, they're recommending doing root canal therapy as a way of avoiding the need for extraction. I've actually done that with cases of cancer patients that denied extraction prior to facial radiation, and then when the salivary gland function is diminished and they start winding up with a mouthful of decay problems that we can't maintain, I've actually done root canals to try to avoid extracting the teeth. We've been successful in some cases with that and not in others. Okay, as I mentioned in the last lecture, With traditional osteonecrosis, using hyperbaric oxygen with increased oxygen tension has been successful in some cases as a treatment modality. And again, that is because traditional osteonecrosis is a blood vessel or a lack of blood flow problem. So you can use hyperbaric oxygen, increase oxygen tension, increase blood supply to the area, and in some cases you'll get resolution. Phil Malika and Robert Harris are also using medical grade oxygen and ozone for both types of problems. Just like some medical doctors are using IV ozone treatment for gangrene and diabetic cases and things like that, they're also using it around the areas and are seeing some improvements with both types. However, the research basically says that hyperbaric oxygen for bisphosphate-induced osteonecrosis is of no value because increased oxygen tension doesn't have any role in whether the osteoclasts are poisoned or not by the drug. So they're saying that it does not help. This is a patient that came in with a draining fistula, so this would be the stage 3B. And this is why he's got the fistula. This is osteolytic activity that goes way down. I wish the x-ray went down just a little bit further. This doesn't look very good up here either. And this is a different radiograph of a different patient that has a big swelling with infection. The jawbone is exposed all the way back to the ramus, both on the buccal and the lingual side. This is what the original radiograph looked like, and they followed this patient for 6 months, and you can see that there was a traumatic fracture that occurred. The bone broke down in 6 months that fast. According to most recent research on the subject, it appears that the jury is still out, but most clinicians and researchers that I could find state that a history of bisphosphonate usage is a disqualifier for most orthodontic practitioners. The fear is lack of movement and increased forces that are applied to try to obtain the movement, the more likely you're going to wind up with a problem that will result in a bisphosphate-induced osteonecrosis. So most orthodontists are not really encouraged about doing this kind of testing. What if you have a patient and you want to know whether you can treat them or not? They're using a serum CTX. CTX is a C-terminal cross-linking telopeptide test which measures the rate of bone turnover and can be used as a measure of risk for developing the bisphosphate-induced osteonecrosis. Obviously, these patients would be off of their medication at this time if you were considering doing any treatment. If you get a level of greater than 150 picograms per milliliter, that is considered a normal and with reduced risk. But with anything that's lower than 100, that is considered at great risk for developing bisphosphonate osteonecrosis, and you wouldn't want to treat them, at least I wouldn't. This can be used for assessing a patient that has a history of taking these and for assessing their risk. There are a few off-label uses: osteogenesis imperfecta, Gaucher's disease, steroid-induced osteonecrosis, and surprisingly, there have been a few that are using it for periodontal disease in postmenopausal women. I'm trying to think. There was a case where they've actually induced osteopetrosis in a 6.5 and a 7.5-year-old child. I forget what they were treating them for, but they were using bisphosphonates and they weren't controlling the doses well enough, and they started seeing pathologic fractures in those kiddos. So you can actually over-medicate with this and create osteopetrosis as well. So here's my warning. With incident rates ranging in the literature, some of them are down in the 0.1%, like 0.6%, but the average of what I saw was the incident ranging from all types of bisphosphonates from 6% to 15%. And with others stating that the incidence is vastly underreported, there is some distinct risk of performing invasive dentistry on patients with a drug history of bisphosphonates. So the decision to treat these patients is yours to make, but it's our hope that this information has been helpful in helping you make that decision. This is my airplane. Being asleep at the wheel can have devastating consequences. If your head's not in the game, you might forget to lower the landing gear. If you're not informed, if you're not aware, if you haven't asked the right questions, you might be getting into a situation that's going to be devastating for your patient. Thanks for your attention.